probably gonna get you on
So
this
before
one,
we
too.
start with the medication, I want to try to see if the vagal maneuvers do work. Some people it works. If it works, then for you, you learn how to take care of this yourself if this ever happens again.
Okay.
Vagal maneuvers means like when you go to the bathroom and you poop and you're very constipated, you have to push really hard. What that does is it slows your heart rate down. So if you do that for me, you're gonna take a deep
I
breath.
did that in ambulance.
It didn't work. Okay. Well, let's try it again, just for kids. While she gets ready. I'm gonna take a deep breath. And you're gonna imagine you're pushing my arm out. Push my arm out. Push, 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 push. As much as you can bear. And
Bless me on the
okay. Because what made you cough? Did they also do the massage in the neck? No. Sometimes what we do is, and this is things that I like to teach anyway, because if you're at home, you can try it, especially if it just starts. You just go around here, where you take your pulse, and then you start massaging like so. What that does is there's a carotid sinus there, there's a bunch of nerve fibers in the little dilated vessel, and when it gets stimulated, it can slow your heart rate down.
Be good
That's
pressure there.
That's why when the karate things and they hold the people's necks, they pass out because they put pressure there and it makes their pressure drop as well as their heart rate. The other things you can try at home are take an ice bucket with water and put your head on it. And the cold sometimes it does it and it slows you down. All right, so we're gonna start with the 6 milligrams of adenosine. You're gonna feel really sick initially. The medicine kind of resets your clock, and until the clock starts again, you feel like you're passing out. So a lot of people complain it's almost like terrible feeling.
Like that, I already kind of feel that way.
You push them. Ready? 6 at a dentist.
So the most important thing about the push is that we do the flush.
This will make sure. Yep,
Yeah,
that's
they
you
do,
got it.
yeah, they do the flush in the ambulance.
Ready? All right, sweetie.
Okay, we're pushing right now, 11:21. And we raise the arm up to make it go faster. This medicine only lasts in your system a few seconds, so if we don't push it hard enough, it just doesn't do anything. Often we have to go to double that dose just to make sure enough medicine gets into you. And there we go.
Okay, here it goes. It'll make you feel weird. It's okay. It's all right. Working. You're doing good, sweetie.
You're doing great. I don't blame you.
Then what I like to do is follow it with some beta blocker, some low pressure to keep it slow, being 5 with low pressure.
Okay. You did great.
And it's probably from, you said you were taking this decongestion for the cough,
I've only done one application.
and like she took it, 15 minutes later she had a bad headache. Then after that she felt the pressure and the heart going fast and a little short of breath. So right now it's sinus, but it's still fast, 123, couple extra beats you can see right here. But that's because your heart's still irritated. I mean, it was just 3 times what the normal rate should be, and now it's still about 50% faster than it should be. So the low pressure is going to slow you down even more. You're going to feel better. In terms of the workup right now, we're going to do a little bit of blood work, check your hemoglobin, your electrolytes, sodium, potassium. And since it was going since 9 a.m., which is took almost 2 hours at that rate, we want to make sure you didn't have a heart attack or something from it. And then we'll do another EKG now that it's slowed down. Let me cover this up here. So that's the first EKG. And a little bit of ST depressions here, and that usually is just rate related because it's going so fast that it can look like ischemia. Right there, a little bit of ST depressions there and there,
With others?
Oh my God.
there.
Others? Any culture, religious?
So we're gonna do another EKG.
You want me to get
So this is the EKG after the low pressure is back to 80 something beats per minute. No signs of ischemia. Remember the ST depressions that were here, they're now gone because they were rate related. So the patient's doing much better and she has no more symptoms.
Okay, so now we're down to atrial dysrhythmias. These are the most common atrial rhythms that you'll see. But again, from the objective, we are just going to talk about atrial fibrillation and atrial flutter. So atrial rhythms, they originate from the foci within the atria and not the SA node. Okay, so this includes aberrancies such as your PACs, as well as the AFib and A flutter. Again, we're not going to discuss PAC, but AFib and A flutter. All right, so for atrial fibrillation, it's basically an uncoordinated atrial rhythm, which is why when you see it, it describes as an irregular rhythm with no discernible or no visible P waves. Can you figure out where the P waves is? No. So it means that when you look at the QRS complexes, they're not gonna march out. So if I take a piece of paper and I mark one R um from one R to another R, they're not going to be the same. It's going to be smaller, longer, smaller, longer. It's in irregular. It's in irregular rhythm. And I'm looking here if I'm trying to find a P, and I'm not sure if it's an atrial fibrillation. So it is uncoordinated. It is irregular in rhythm, and where you will see an irregularity, meaning the R's don't march out. They it's an irregular rhythm. You can't find a piece, they're not visible. And what happens is when you check the patient's pulse, is the patient's pulse is going to be irregularly irregular. So in your book 700, page 723, chart 26-3, it gives you the classification of AFib or atrial fibrillation. It's listed down right here in your PowerPoint as well. You have the paroxysmal, persistent, long-standing, and the permanent types. So for signs and symptoms, you're going to see this. Oftentimes, the patient will complain of palpitations. Are you palpitating? They can feel that. So remember, the guy I was talking about earlier, he was cleaning out his camp, and he was short of breath. He was tired. There's exercise intolerance, and he was having such a hard time going up and down the stairs. He also has complaints of general malaise. Sometimes they are not symptomatic, and they don't even know that they have this. So they can be compensating and handling it. Um, I have another woman who came in and she's like, well, I would have known if I would not have known it if I didn't go to the doctors. And they made her come in and she was irritated and she was there and they can't convert them. Sometimes they'll do rate control with this. And what this particular woman, she didn't want to stay for the ablation, and she's like, well, I'm checking out and I want to go home. So for someone like that, maybe you could do, maybe you can do that as well. But she had no clue she even had it. But again, sometimes patients get sick from it. They get severely hypotensive. This is more with your hemodynamic collapse. So these patients can have more symptoms, like more complicated symptoms. They can have chest pain, they can have pulmonary edema, and they can have altered level of consciousness. And it's a sudden thing because their bodies are not compensating and they become hemodynamically unstable. So again, symptoms these patients will have palpitations, short of breath. I mentioned that every now and then, intolerance to exercise. They can have fatigue, irregular pulse, and also with this, when you feel the apical and radial pulses, there's going to be a difference between them, and most often this is called the pulse deficit. So that's also one thing you want to learn. Anyway, nursing interventions, what you're going to do is, if it's chronic, well, we'll usually try to control the rate. So rate control medications, there have to be a continuous ECG monitoring, or a tele, as you call it. Obviously they have to be in the hospital. A good cardiac assessment is important. You want to remember the TEE, the transesophageal cardiogram, echocardiogram that I mentioned earlier. You want to determine if there are, what's the purpose of the TEE? You want to determine if there are no clots. Okay, the difference here is that the TEE is better than the regular echo, wherein the patient just put a probe in on their chest or in the skin. So the difference is that you can with the TEE you see the backside of the heart and you can determine that there is nothing pulling there either. So that's for rate control. You can also use beta block your medications for rate control. You want to put them on. What medications are those again for rate controls? Yep, your beta blocker again. You want to decrease the heart rate. Atenolol, propanolol, metoprolol. Those are the guys. Um, Other kind of rate control medications you can think of. Yes, we have the calcium channel blockers. So those are the things. Another way is rhythm control. So usually what we do is the cardioversion of the patient. So if the patient is hemodynamically stable. So so what happens here if they are less than, you can only do cardioversion. Remember this, you can only do cardioversion when they are their symptoms started within the 48 hours. If the patient has been on Coumadin therapy and found to have no clots, then again they can also do cardioversion. Um, so make sure you do the TE within the 48 hours. Check for clots. Um, Usually they're gonna put them on, or you put the patients on heparin, um, to prevent more clots, and then we can cardivert them. Another kind of medication, we call this the anti-arrhythmic medication or dysrhythmic medications. We have such the amiodarone, that's one of them, and sotalol. Sometimes we give these patients medications prior to cardioversion as well to prevent massive collapse. So those are your pharmacologic cardioversions. I mentioned the rate controls, rhythm controls, so and your coumadins, your antithrombolytics or anticoagulants as well. So again, we want to make sure you cardiovert them when you have an irregular rhythm with no discernible peace. These are your AFibs and the AFloods. And again, you want to make sure you think of cardioversion. You don't want the increase of risk of clots. Um, traveling around the system. You don't want to do or promote or complicate the patient with PE or stroke. So again, within 48 hours, you can convert them. But if not, then medication is probably one of the things that we can do acutely. So safety, prevention of stroke, and prevention of other clots would be your goal here.
So here's another one. It's atrial flutter. So obviously you can see it's a sawtooth appearance. And the way I always remember this sawtooth is like a shark's flattering tail. So what is atrial flutter? Atrial flutter occurs because of conduction defect on the atrium and causes a rapid regular atrial impulse at the rate between 250 to 400 beats per minute. Because the atrial rate is faster than the AV node can conduct, not all atrial, not all atrial impulses are conducted into the ventricles, causing a therapeutic block at the AV node. This is an important feature of this dysrhythmia. If all atrial impulse were conducted to the ventricle, the ventricular rate would also be 250 to 400 beats per minute, which would result in ventricular fibrillation, which is a life-threatening dysrhythmia. So anyway, what are the causes or what are the symptoms, I should say, of atrial flutter? A patient will have chest pain, short of breath, um, low blood pressure as well because of your low cardiac output. What are your medical management? So first, you want to make use of your vagal maneuvers. Remember, these are that your heart rate or patient's heart rate is high, so they're very tacky. So obviously, you want to like use your vagal maneuvers. And what are those again? Yes, your carotid massage, the bearing down. You want a patient to like gag or say, "Big me a big cuff." So forceful, sustained cuffing and those cold stimulation, or you want to immerse the patient's face in water, which we don't normally do that, but it kind of helps. And also, what other medication can we give to help with the atrial flutter? We do use your adenosine. So, adenosine, what is our dosage again? Yes, 6 milligram, fast, like super fast, followed by 20 mLs of saline, and you raise the arm. And then if it doesn't work, you give another 12 milligrams of adenosine, and that's it. So, what does adenosine do again? Recap: adenosine causes sympathetic block and it slows the conduction through the AV node. It terminates the tachycardia. Optimally, it will facilitate the visualization of the flutter waves for diagnostic purposes. What other things can we do for atrial flutter? Or what other medications? Just like your atrial fibrillation, you want to start with antithrombotic therapy, your anticoags and antiplatelets. Do you know anything, or do you remember all the medications? Anticoags, yep, you have your heparin and your coumadin or warfarin. Antiplatelets, like what again? Yes, your aspirin, your Plavix, and all those. Um, you can also treat a flutter with rate control medications. Again, you can use your beta blockers and your calcium channel blockers. You also use some of the antiarrhythmics shown in page or in your table 26-1 of your brother book. And you can also treat a flutter same with your AFib, with anything that converts the heart rhythm or to prevent atrial fibrillation, going back to your anticoagulants. Now, with this other medication, if doesn't work, doctor will probably order for electrical cardioversion. I'm so sorry, electrical cardioversion, which is often successful in converting your atrial flutter to sinus rhythm. However, okay, this is the big thing that you need to remember. If the flutter is greater than 48 hours, so if the patient complained of chest pain, went to the hospital, and EKG shows atrial flutter, and the patient has been complaining of on and off intermittent chest pain, palpitation, short of breath for the past, say, 96 hours, then the patient cannot get an electrical cardioversion. So what the doctors will probably order is the doctor will decide to the patient will have to do or undergo the procedure called transesophageal echocardiography or cardiogram, which is our TEE. It's done under um before it is done before cardioversion. The reason for doing the TEE is you want to make sure that the patient doesn't have any cardiac or heart clots, because if they do, blood clots can break free by cardioversion. So that's the reason why you want to do your TEE. If your doctor finds clots or blood clots in the heart, then your cardioversion procedure will be delayed for approximately 3 to 4 weeks, depending on your cardiologist. Um, Other contraindications for your cardioversion is in any arrhythmia that is known to be incessant or continuous, and because these rhythms recur immediately or soon after, so it's useless to perform cardioversion. So that's that. These are your medications. These are a sample. And looking at the picture over here, your heart rate is, don't follow what's on the slide, but follow what the book says. It's 252, 400 beats per minute. But obviously, the P wave is sawtooth. The rhythm is regular or it can be variable. Obviously, there's no PR interval, and the QRS is less than 0.12 seconds. Now you have learned the most important atrial dysrhythmias, or the most common ones. You've learned about your atrial fibrillation, you've learned about atrial flutter, and you've learned about supraventricular tachycardia and the medications that would help them. However, there is what we call a cardiac rhythm therapies. So if the atrial fibrillation does not respond to medications or electrical cardioversion, this may be treated by cardiac rhythm therapies, and including this includes the following: we have the catheter ablation, we have the maze procedure, we have the convergent procedure, and I also want to show you a video of the left atrial appendage occlusion. EPS or electrophysiology study is another thing. It's not a CRT, but it is something that you like probably want to see on, and it's found on page 738. EPS is an invasive procedure used to evaluate and treat various chronic dysrhythmias that have caused cardiac arrest or significant symptoms. So basically, the next 1, 2, 3, 4, 5 videos that you are gonna watch will be very helpful in understanding the procedures. I am a visual learner myself, so if you want to just read the book, it's all in there. It's described in the book. I don't need to say it over here or define it here. But however, if, like I keep on saying, I'm a visual learner. If I see it, I would be able to understand what the procedures are all about. So um I'm gonna stop talking now, and I want you to watch the videos of all these therapies just for information purposes. And I feel like you would understand better if you see the pictures. And I strongly um, suggest you watch it because it's really gonna help you understand these procedures.
It's at the heart of many people's health problems. An estimated 5 million Americans suffer from AFib,
and about a third of those people are going to have a stroke.
which explains why we hear so much about it, and more treatments are being developed to manage or resolve AFib. An irregular heart rhythm is caused by errant electrical impulses. If drug therapy doesn't control AFib, many people will move on to ablation procedures, which redirect current through the heart.
The nerve endings in the back of the heart are ablated so that you can prevent conduction in all different directions and only allow conduction of the electrical impulses in certain directions.
There are many ways using various energy sources to ablate the tissue, including microwave, radio frequency, and cryoablation or freezing. But the gold standard procedure is the maze. Once a major open heart surgery, it's now evolved with less invasive options built on the same principles.
You are creating a pathway which looks like a maze for electrical impulses to follow.
The original maze required open heart surgery. Now there are several variations. Lee Memorial Health System is offering a new maze technique, which doesn't involve an open heart operation.
The newest procedure now is a standalone hybrid maze procedure where we do part of the procedure surgically. We go in between the ribs minimally invasively on both sides. We do an ablation procedure. About a month and a half later, those patients are brought back in to the EP lab, and then a few more ablation lines are done to complete the procedure. This allows a patient in 2 steps to get what used to be an open procedure, a full maze 4 procedure.
An option many people can better tolerate, achieving the benefits of the gold standard maze without tarnishing its results. For Lee Memorial Health System, I'm Amy Osher.